So we're going to move on to our program tonight, where we're going to try to answer the question of America's end-of-life ethical dilemma. Is there a time when it is okay to die? And tonight we're privileged to have Dr. Monica Williams-Murphy to share her insight into this question that will impact us all as physicians or as patients ourselves. Dr. Williams-Murphy is an award-winning writer and board-certified emergency physician with expertise in medical directives. She practices in one of the largest emergency departments in the nation at Huntsville Hospital, where she also serves as the community as a medical director for advanced care planning and end-of-life education. Additionally, she serves on the board of directors for both Hospice Family Care and Anam Cara Los Angeles. Did I pronounce that right? Close enough. Dr. Murphy is a medical expert and contributing writer for thirdage.com, the leading online baby boomer lifestyle site. She is on faculty at the University of Alabama at Birmingham School of Medicine, Huntsville campus, and is an appointee to the American College of Emergency Physicians End-of-Life Task Force. Her writing and speaking focus is on empowering patients and families in critical and end-of-life decision-making, and her consulting work centers on the same. Her book, It's Okay to Die, and companion website are tools for transforming the end of life into a time of peace, closure, and healing. Dr. Murphy's blog has also appeared in the New York Times Health Around the World column. Her lecture has been broadcast nationally by the Alabama Department of Public Health and received rave reviews at the National Hospice and Palliative Care Organization's Management and Leadership Meeting in 2014. Her end-of-life preparation checklists have been adopted by the UK NH campaign Be Ready For It, endorsed by the Norfolk and Suffolk Palliative Care Academy. She also hosts the trendy Death Cafe in Huntsville, Alabama. So we're delighted to have her here, and please welcome me and join her.
Thank you. It's an honor to be with you. That was a lot of boring information about me. I'm sorry about that. So you know some things about me. Let me make sure I'm very clear on who all is here. Please raise your hand if you're a medical student. Yes, awesome. Thank you for coming. Residents, raise your hand. Very good. Attendings, physicians, raise your hand. Wonderful. Any dentists, raise your hand. Raise your hand if you do something far more interesting than anything I mentioned. Yes. I may or may not want your job, so, all right. And by the way, I do feel like I'm home. The Gulf Coast is home for me. I did go to the University of South Alabama Medical School, and I think Dr. Umana taught me. I just don't remember. I was sleep deprived. It was long before the era of resident work hour limitations. I was a med student there. Went to University of Virginia for emergency medicine. So, let me start with a couple of very dumb questions. They say there are no dumb questions, but these are dumb. They're simple, just to orient us to our evening. Please raise your hand if you've ever had a patient who died. Yeah. Please raise your hand if you've ever had a family member who died. Please raise your hand if you've ever known anyone who's died. Please raise your hand if you've ever died. This gentleman has his hand up. There's usually one person in a crowd. Don't be surprised. And so the point being is that death, dying, and the end of life is one thing we all have in common, but very few people talk about it. Now, in contrast, we all talk about the beginning of life. We enjoy talking about that. From the moment someone pees on a stick and it says positive, we have planned what that new baby will wear home. Grandparents know exactly, they've already worked it out in their mind, exactly what things are going to look like and the whole event. And we have the sex reveal party. You know, it's all very interesting, elaborate cultural celebrations about the beginning of life. We plan for it and talk about it, and things generally go our way because it's a topic of conversation. But in contrast, very few people talk about the end of life. If you don't talk about something, you rarely plan for it. If you do not plan for it, things rarely go your way. And it is the rare person who can celebrate the end of life. But I think we need to change that, you see. In medicine, we've lost our way. We have reduced death and dying to a medical event. And true, it is a medical event. It's a physical event, but it's also an emotional event, it's a social event, it's a family event, it's a spiritual event. And we have to make space in medicine to recapture that. That is something we have lost with the advent of modern technology. Everybody on the street out there thinks that we have the eternity pill in the hospital or the shot to make death optional, right? And we're not talking about it. So our patients think that maybe this topic doesn't apply to them. But that's wrong. We fail patients when we do not prepare them for the end of life. And my really strong words are this: it's moral medical malpractice when you don't tell your patients where they are on the map of life. We rob people of the opportunity to create closure at life's end if they don't know the end is coming. So I'll beg you tonight to reintroduce this topic to your practice, get comfortable talking about it. We already talk about taboo things. We ask people, do you want to kill yourself or others? Do you have sex with men, women, or both, right? Why not add one other taboo thing to your questioning with your patients? You can do it. So I'd like to tell you about a moral crisis I had in 2010, which is the reason that I'm even here. See, I'm an emergency physician. I'm not trained in hospice or palliative care, and I'm here talking about a hospice-esque topic. So how did that happen? Like, I'm an acute care doctor. How does this relate? Well, being trained in the emergency aspect of medicine means that if you're 8, 80, or 180 and you roll in the ER, you're dying. My entire instinct and reflex is to do everything to save your life. As a matter of fact, when I was in the Atlanta airport earlier today, I saw a guy looking kind of diaphoretic and holding his chest. I already identified the AED. I was ready. I'm trained to do that. It's almost as natural as breathing, okay? So it's very hard for me to think and stand down rather than act. So that's my background. In 2010, I applied that instinct indiscriminately, regardless of where someone was in proximity to the end of a natural life. Unless they rolled through the door waving a DNR, I didn't ask anybody questions at all. I just acted on the moment. One night at 4 a.m., something changed for me. We have an 86-bed ER, very big, and we carry cell phones around to talk to EMS. So EMS called. It was 4 a.m. when all the interesting patient comes in, right? And I have to call you in the middle of the night. I know you hate that. So it's 4 a.m., and EMS calls and says, Dr. Murphy, we have a 90-year-old patient from a skilled nursing facility, and she's septic, she's in shock, we need a bed, we're 5 minutes out. I said, okay, put her in bed 45, I'll meet you there. So they rolled around the corner, and I started walking with them, and I got a report, and it was obvious from her vital signs that her respiratory rate was equal to her blood pressure, which is bad. We should add that to our sepsis protocol, right? Respiratory rate equals systolic blood pressure equals danger. Maybe call the morgue. They might end up there. So she looked terrible. She was mottled. She was diaphoretic, tachypnic. Her pressure was about 60, and her respiratory rate was about also. She weighed 70 pounds. She had multi-infarct dementia. She had not moved or spoken of her own accord in 2 years. All limbs were contractured, fixed in place. She had a feeding tube taped to her belly. And I asked the nurse to start a second IV as I went through the paperwork. And on the 100th page, you know, there's always 100 pages from the skilled nursing facility. On the 100th page was the medical directive, and it said full code. And the noise you just made is the first time I ever groaned aloud about the status of a patient or the plan. I thought, really? And I remember asking myself, I wonder if this woman is in an unnecessary state of suffering. I went over to examine her. She was covered in bed sores. And as the nurse started the second IV, she coded. And so standing over, she was pulseless and apneic. And I said, call in respiratory. She's full code. I started CPR. I did the first chest compression. You know exactly what I heard and felt. Snap, crackle, pop. It felt like 20. I almost had to break her arm to get it out of the way to do effective CPR. And in the middle of this crunching and munching, something inside of me kind of broke. And I looked at my nurse, and I began to cry. ER docs don't cry, by the way. That's uncool. I looked at my nurse and said, what are we doing? This could be wrong. Instead of this, somebody should be holding her hand, saying, thank you, I love you, and goodbye. How did we get to this moment? How is this the default of the system? Did her family think this is love? And then I asked, I wonder if anyone ever asked her if this is what she wanted. I didn't know. I didn't stop CPR. I delivered full ACLS protocol for 20 minutes. And she died anyway, as she was already going to. The only difference is that there was a great big hole in her chest from the force of my CPR. And there was not an ounce of dignity for this woman. And I felt guilty. I thought that I had failed her in some way. And I had all those questions I asked her in the middle of that code, and I didn't know the answer to them, and I was shaken. Because suddenly what I'd been doing and been trained to do, I didn't know anymore if it was right. So I walked out of the room and thought, whoa, I got some work to do. I got some thinking to do. The very next week, I had another patient who taught me a similar lesson. Paramedics called ahead and said, Dr. Murphy, we have a 60-year-old male. He's obtunded. He's in respiratory distress. We got him on BiPAP. And I think 60 is young now, in my opinion. So this 60-year-old male rolled in. He had temporal wasting. He had 4+ edema. He's really skinny and cachectic. I asked his wife, what's his medical history? And she says, he's got stage 4 cancer and we're receiving chemotherapy. I said, well, how's his week been? What's been going on? Because he looked like I should know where he is on the map of life, that he would be in an end-of-life phase. She said, well, he hadn't gotten out of bed all week, and he hasn't really been eating much. Okay. Well, he was too confused for me to ask him his wishes, and I was starting to think about asking people their wishes. So in the absence of decisional capacity, it was my job to turn to a surrogate decision maker, which was by default his wife. And so I sat her down, and I said, ma'am, does your husband have a living will? And she was dumbfounded that I would ask such a thing. Well, why no? Why would you ask that? Really? So I asked her, has your husband ever told you what he would want or not want in the setting of a critical or end-of-life situation? No. Okay. So I sat her down, realizing that she had no clue where we were. And I held her hand and I said, I am so sorry to have to be the one to tell you this, because I'm a stranger. You've never seen me before. Okay? You don't know who I am. But your husband is showing dying signs. And based on his previous existing diagnosis and his treatment plan and what you just told me about his week, we may be there. The x-ray showed multi-lobar pneumonia. His white count was 26,000. His electrolytes were completely out of whack. And he was in respiratory failure. And so I told her, I said, we now need to make a decision that he would make if he could stand here and see himself and hear the bottom line. What decision would he make? That's what we should support. And so I gave her the options. I said, if he would want us to, I could tube him and put him in the ICU. Or if he would want us to, knowing what you're hearing, I could admit him to a regular floor bed. We could call in the palliative care team. He could receive oxygen, antibiotics, fluids, and we could still care for him and treat him. But honestly, ma'am, I think he's dying regardless of what we do. And so the question in this moment is, how do I create a moment of peace for you and peace for him? And so she wrung her hands, and what did she say? Do everything, which happens 99% of the time when no one's ever had a conversation upstream in healthcare. So I tubed him and put him in the ICU, where he died alone in the middle of the night. And I felt guilty. I felt like I had failed this man and his wife by not providing them with a peaceful dying experience to the extent that it was possible. But more importantly, I felt that every healthcare provider upstream who had ever seen these people failed them by not preparing them for that moment. So I learned 3 very important lessons from those patients and many more like them. It was a rough week, let me tell you. The number 1 lesson I learned was, and this applies to us, we need to make our own plans for ourselves. We need to do the difficult work of thinking about what quality of life means for us and what we do and do not want at the end of life. Because you do not want to shift that decision burden to the people that you love. No one that you love should ever have to make an uninformed decision for you. Number 2, The family needs to hear this decision, and the healthcare system needs to support it. So not only do you need to make it, people need to see it written, and they need to hear it from you from the horse's mouth. And the third lesson I learned, which was the most difficult for a physician to learn, by far the most difficult, is that there's a place and time at the end of a long life or terminal illness when it's okay to die. I don't have the eternity pill, neither does anyone else that I know. And so when that time comes, how do we prepare for peace? You see, I left medical school and residency somehow thinking that death was failure. That's what morbidity and mortality conferences do for you. You get freaked out. What did I do wrong that killed the patient? And in 2016, for me, death sometimes is still failure. There are people I really, really want to save, and I can't. But more important for me in 2016, this is my new perspective. Failure to prepare people for a good death is failure. To the extent that we try so hard to give people a good life, by golly, we better give them a good death too. That's part of what you signed up to do. Cannot abandon people at the end. So those were professional lessons. I think you would all agree with me that it's different when it's personal. So I had to research hospice literature to understand the natural cycles that occur at the end of life. I was not taught that. That was not a part of emergency medicine training. I was trained to act on the moment, not look at the big pathway. By the way, raise your hand if you feel like you got really good end-of-life training, how to talk about it and the pattern. Raise your hands high. 1, 2, 3. 3 of you. All right, there you go. There you go. It's difficult. So in the middle of researching this pattern that I didn't understand, apparently, I began to write a book. At the end of the chapter where I describe what happens naturally at the end of life, a light bulb went off for me, and I thought, oh my God, my very own grandmother fits this pattern. And then I didn't realize that until this moment. So my grandmother was an 86-year-old independent living female, lived in her own home in Tuscaloosa. I lived 2 hours away. Things had begun to change for her. She was the family matriarch. She told us all what to do, and we said, yes, ma'am. You know the type, right? She stopped growing tomatoes, which is a big deal. I'm from a family of farmers. If you're not growing something, there's something definitely wrong with you. So she stopped growing tomatoes. She was beginning to fall, multiple falls. Went to the hospital 3 times, 3 admissions with no clear diagnosis, very complicated course of symptoms. She was losing weight. She was sleeping more. She was giving things away. She was beginning to write people's names on pictures on the back of the wall. But most blatantly, at her last birthday, she told us, "This will be my last." See, the dying often know they're dying. It's the rest of us who won't hear it. We won't give audience. You know what we said? "Oh, Granny, you're going to be fine. You're going to outlive us." We thought that was love to say that, you see. So here I was suddenly getting it. And so I had the day off. I called up Granny and I said, "Hey, Granny, I'm going to come see you and we're going to do a living will." And she said, "That's a good idea." I was like, "What? It's going to be easy. What's the big deal? We should be talking about this all the time." So I got in the car. I printed off the Alabama State Living Will. I was all proud of myself, like, all right, going to get this stuff in order. Started driving down the road. Remember I told you Granny was falling, right? Driving down the road. My cousin called me, who lived across the street. My cousin said, hey, Granny's falling. I'm over here. She pressed her life alert button, and she's on the floor. And I said, "What do you mean she's on the floor? Conscious?" She said, "Yeah." And I said, "Is she okay?" And my cousin said, "Granny says she's okay." Granny said, "Drive faster." Okay. What? So I drove faster. And halfway down the road further, my cousin called back. She said, "Granny's unresponsive. I'm calling 911. I couldn't believe this. I mean, I was coming to talk about this, not to have it happen, which proves I was too late, right? So I beat the paramedics to the house. I went in, and my Granny was awake. She was conscious. They had her in the recliner. But she looked like a patient. I'd never seen her in that role before. This strong woman was now dying. She was pale, diaphoretic, sweaty, but completely oriented. And as I walked in the room, She reached out her hand for me and she said, "Monica, I don't want to go back to the hospital. If the Lord's ready for me, I'm ready to go." My family filled the room. The paramedics showed up, and I knelt beside her and held her hand. And I said, "Granny, I failed you. You see, I'm into failure. I got this." I haven't gotten us ready for this. I'm the only person ever to go to college in my family. I'm the family doctor. I mean, I'm the one that's supposed to be preparing people, and I didn't get it till today. We don't have hospice here, which she was probably hospice appropriate. We don't have home health. We don't have anything. It's just us, the family, and the community here. And they're not going to be okay with you just staying because we're not prepared. We haven't talked about it. So I said, "I promise you, if you'll go in the ambulance and I'll go with you, we'll go to the hospital, get ourselves organized, and I'll bring you home. And I'll take care of you myself." And she said, "Okay." But before we got in that ambulance, I had come to ask her health care wishes. And I knew that we couldn't leave without my family hearing it because I had just learned that from the other patients. It's one of the most difficult conversations of my life. I told my family, I said, "Come over here and stand near Granny because her voice is weak. I'm going to ask her some questions. It's going to be hard to hear this, but whatever she says, we're going to obey because this is not about us. This is about her." So I asked her the hardest questions you'll ever ask someone you love. "Granny, when your heart stops beating," not if, when, "do you want us to do chest compressions and shocks?" And I talked about the risks, benefits, and alternatives to CPR, broken ribs, pneumothorax, hemothorax, solid organ injury, prolonged ventilators. She said, "No, I'm okay to go." "Granny, when you stop breathing," talked about the breathing machine, risk, benefits, and alternatives, trachs, ICU care. And she said, "No." That was hard to hear. That was hard to hear. But I looked at my family and I said, "You heard that. That's what we're going to do, or not do, rather." And I looked at the paramedics and said, "Can you obey that?" And they said, "You're the doc." So I gave my medical control number real quick. And we went to the hospital. So we went to our local facility. And in the emergency department, she told the ER doc the same thing, and in the admission orders were written, "Do not resuscitate, allow natural death." And we got placed in a regular floor bed. And I'm so pleased that I had the guts to have that conversation and that she gave us clear answers. Because over the next 18 hours, my granny died in my arms, right there in room 437. And it was one of the most beautiful and painful experiences of my entire life. But I got to hold her hand and say, "Thank you, I love you, and goodbye." It was a sacred and holy moment, to be honest. The nurse walked in, a 50-year-old male nurse. He'd done this for years and years, and he said, "I want to thank you for honoring her wishes and letting her go this peacefully." He said, "As a matter of fact, I've never seen anything like it." And I looked at him and I said, I've been a doctor for 7 years and I haven't either. But I think this is the way it's supposed to be. I think this is what the hospice folks do." I was embarrassed. I'd like to draw your attention to this photo. It's one of the great pictures of my life. It's a picture of me holding my grandmother's hand 3 minutes after she took her last breath. My grandmother taught me personally the same 3 lessons that those other patients taught me professionally. We need to make our own plans for ourselves. Our family and the healthcare system needs to hear it and obey it. And there's a time when it's okay to die. What a lesson from someone that you love. I hope you can hear her message. It's my message for you and my message for the entire healthcare system. We got to do better. Disclosures. All right, so this is what we're going to talk about tonight. We're going to keep calm and discuss death. Death is not contagious. You can't catch it by talking about it. I've been talking about death for 6 years, and I'm not dead yet. Stay tuned. It's coming to us all, right? All right, those are our topics. We'll just get to them. Here's the biggest deal statistic in the United States regarding end-of-life issues today. A Gallup poll in the late 1990s found that almost 90% of Americans say they want to take their last breath in their very own home, held in the arms of those who love them the most. So this is kind of a dark photo, but it's a picture of a man dying in his own bed. His wife is holding him, and here's a heart player. So if a heart player happens to show up, so much the better. That's what the hospice folks can do. I would like to die in my own bed with a cat at my feet and some Bach playing. Sounds nice. My husband would like to die in his own bed with some dogs running around and some Genesis playing. He's a weird guy, but you should get what you want at the end of life. Sounds a bit rowdy for me. So that's what 90% of Americans want. But the stark reality is that over 70% of us die in medical institutions, predominantly hospitals, but also skilled nursing facilities. And way too many of us at the end of a long life or terminal illness die in the ICU getting the full court press, and that is not what people say they want. So somewhere along the line, we're doing something wrong. Here's one of the problems. Only 20 to 30% of Americans have had any conversation with their loved ones about what they would want or not want in a critical or end-of-life situation. Only 20 to 30% of Americans have advance directives or living wills. Raise your hand if you have an advance directive. All right, you're my people. The rest of you, I'll check back with you tomorrow. There's one in your pamphlet. Okay, very good. That's my message. Okay, so there are 3 cultural variables whose present configuration have created the 90-70 dilemma, in my opinion. I'm also an anthropologist because I couldn't figure out what I wanted to do before I decided to be a doctor. Okay, so the first cultural variable here is the knowledge that average Jane and the Joe on the street has about death, dying, and the end of life. And I'll tell you that in 2016, the average American knows very little about death, dying, and the end of life. It's a medicalized event. It's managed in medical institutions. It's not considered a natural event anymore. This is a photo from the 1800s. Kind of an odd photo, don't you think? A man who died, and his death and dying were managed by the community. Okay, died in his own home. Family built a casket. They buried him right there. So interestingly enough, in the late 1800s, the only photo you might have of someone you love was a perimortem photo. Can you imagine what their mantles look like? Whoa. Even mothers rushed their febrile babies to the photographer to get a last or only photograph. So was death and dying any less trying to the human soul in the late 1800s? No, I'm not saying that at all. I'm just saying that people knew what it looked like, they knew the pattern, they knew what to expect. It was tightly woven into the fabric of everyday life, not separate like it is today. The second variable is the quality of our modern human relationships, and I'll tell you something you already know. We live in an emotionally fractured society. This is huge when someone lays dying. We cannot divorce emotions from medical decision making, so today I will tell you that we should manage emotions and be emotionally present to have these types of conversations. The third variable at play here is what average Jane and Joe on the street believes about what happens in the house of medicine. And I told you, they already think we got the eternity pill, right? So they think we're working miracles in here. And sometimes we are, okay? But we haven't solved the problem of death. Now, Google says they're getting there, but I don't know about all that, all right? The Google boys are trying to solve the problem. So this, of course, is a photo of a ventilator. And we've come to a time in history where people think at the end of a long life or terminal illness that increasing use of this is going to buy us more of this. And that, my friends, in general, is a lie. It's a lie. And we, the healthcare providers, need to be telling people the honest and compassionate truth. So this is how I believe these things are presently related. We live in a time where we're fighting death at all costs, and I'll call that our ICU medicine, high dependence on that. And to the extent that we've fought death at all costs, we've actually altered the natural contours of death. It looks very different to die in an ICU setting than it looks to die at home under hospice conditions. I go in the ICU and I can't tell who's about to die because everything's artificially supported, right? No wonder the family doesn't know. To the extent that we're fighting death at all costs, we're not doing the emotional work required to be okay with dying, right? And then to the extent that we don't know our loved one is showing end-of-life signs, and we've not done the work of closure that's required at the end of life. To that extent, when that person rolls into the ER, that family will say, Dr. Murphy, yes, do everything. Put her on the full court press. I'm not ready, and I didn't know. So these are our issues. Let's talk about them in detail. Why is it that people know very little about death and dying? These are generational changes that have occurred over time. 100 years ago, the vast majority of Americans lived on farms. Raise your hand if you've ever lived on a farm. Me? Yes, sir. Dr. Umana, did you see the birth and death of animals on your farm? That's correct. So the birth and death cycle was embedded in everyday life. So up until very recently, I lived on a farm with my daughters and chickens. So my girls have seen chickens hatch and little baby chickens run around, and my daughters have seen chickens die. Some of the chickens died of old age, some were eaten by us, some were accidentally eaten by the dog. Whoops. Okay, sorry about that. My middle child calls that the cycle of life. She knows what it looks like. Fast forward to 2016, only 2% of Americans live on farms, and even our animals die in medical institutions. We take our animals to the vet to be put down. We have hidden an entire generation from the cycles of life and death. If you are a middle-aged American living in a large city, you may have never seen a single thing die in your entire life. So how are you supposed to know your mother's showing signs? You don't know. And the healthcare providers aren't discussing it. So generational changes. Other reasons that people know very little about death and dying is that it's really not polite to talk about this topic. I'm surprised any of you are even here. I guess it was because of the work you had to do. So as an example, the day that I went to see my granny, the day she died, I called up my dad and I said, hey Dad, I'm going to see Granny and we're going to do a living will. And he said, don't you go down there and tell her she's dying or anything. And I said, well, I don't have to. And I mean, that's what she's been telling us, right? And very rhetorically, I asked, why is it that we can't talk about one of the most fundamental facts of life? That it ends. Well, why is that? Well, there's one group of people that I hold responsible for why we don't talk about death and dying. Doctors, raise your hands. Hi. Higher. You're all in denial. It's us, okay? Physicians hold a priestly role in society. There's very little that happens and does not happen in the house of medicine that we did not write an order or make it so or start the conversation. Patients think if you're not talking to them about it, that it's not a priority or it doesn't apply to them. Well, that's wrong, okay? The whole system hinges on us starting. We have to carry this role. It's a sacred role. We have to carry it honestly, and we have to tell people the truth. Now, we're not very good about it because we already saw the number of hands that were raised for people who were trained on how to have this conversation. But there's one group of people that we really should not ignore. Are any nurses in the crowd? Nurses? Very good. Nurses are smarter than doctors. This is no surprise to you, right? Okay. This is how. So doctors are trained very narrowly and deeply in the biomedical model of medicine. So I see Pam as a group of organs and organ systems and a beautiful bag of skin, the integumentary system. But then a nurse sees me as organs and organ systems, and they know my BU and creatinine and F, but also sees me as Monica. I'm a mother, I'm a spouse, I'm a member of a religious community. She sees kind of the bigger me. Nurses are trained in the biopsychosocial model of medicine. They have a higher level of interaction and depth of relationship with the patients than we do. Nurses are trained better on end-of-life patterns than we are. Nurses are trained on patient education. Do you see where I'm getting here? They're better, okay? So we should free nurses and nursing staff to start the map of life conversation. And you really want a powerhouse? Find a nurse practitioner to do this work for you. It's amazing. That's marrying the knowledge of a nurse with the knowledge of a provider. And Medicare will pay them to have these conversations. We'll talk about that later. So nurses would like to free them to do so. We have clergy and case manager friends who are hung out to dry when we don't tell patients the truth about where they are on the map of life. So I've got clergy friends who say they are invited to come in and pray the patient back to life, when in fact they should be praying for a peaceful passing. I mean, they're stuck between a rock and a hard place because we haven't told the truth, right? Case managers go in to discharge patients to hospice, and they're the first person to tell the patient they're dying. That's rude. We shouldn't do that to them. We should be the ones to tell them, okay? All right. So let's talk about this emotionally fractured society. This is also a view of human history. If you go back to the pre-industrial era, back to the dawn of human conscience, we lived together in a similar pattern then. And some of your rural population still lives this way. We lived in small villages or village-like settings. In these settings, your families were your neighbor, or you had family-like relationships with them. I grew up this way. My entire little community were my relatives. I couldn't get away with anything. It was terrible. But we hunted and gathered food together. You know, we grew crops together. I was poor, you know. So we fed each other. And what this fostered was a deep sense of connectedness. We knew each other deeply, and we were deeply known by others. This, my friends, is hardwired in us. This is what we desire, whether we're willing to admit it or not. Beginning in the industrial era, families began to fracture. Father or older brother had to move to the cities for work. And then fast forward to 2016. The vast majority of us move away from where we're born, we commute away from where we live, and we're just as likely to have our face turned toward a computer screen as toward another human being. And boy, don't we know that in medicine. How much time do you sit in front of the computer rather than your patient? So what happens? Emotionally fractured society. We live far apart in space and time, and we're distracted from each other by technology in our presence. This complicates end-of-life decision-making. All right, we live in this time where we're fighting death at all costs, right? We fight death in ambulances, ERs, ICUs, skilled nursing facilities, and the whole gamut. All of us in healthcare, that's our job, is to fight death at all costs. At times, it seems. But historically, things were different. 100 years ago, there was really nothing to fight death with. So let's imagine a scenario and compare it to today. So let's imagine it's 100 years ago, and you're walking along the creek path, because that's all you had then, and you look down, and you see your Uncle Wilbur. He's 90, and he appears to be dead on the creek path. What do you do? What do you do? Louder. What do you do? I can't hear anybody. Bury him right there. That's what I'm talking about. Last week, somebody said, roll him into the creek. The week before that, someone said, take a selfie with him. I was like, no, it's 100 years ago, my friend. But of course, no one called 911. Now, that was my whole point, right? So no one calls 911. And so you probably take him home, right? You take him home. What do you do after you get Wilbur home? Wash him, call the family, prepare him to be viewed, right? So you would either put him in his bed or maybe the dining room table. You would push him up to the bay window, because that's what bay windows were for, visiting the dead. Did you know that? Don't take the bay windows out of your house. You might need them, right? That's what they were for, so the community could come visit the dead. Interesting. So, you know, we're deep Southerners. Someone would have to cook some casseroles, and we'd have to show up and talk about Uncle Wilbur. He could catch a big fish, or at least tell you could, right? Someone would go get a pine box, build it, and then you'd bury him together. Now, did you hear anything about a healthcare provider there? No. The family doctor may have shown up simply to say, I'm so sorry, Wilbur was a good man. Death was not reversible. We didn't have the technology. It was not the default of the system. So, it's tomorrow, and you're walking along Park Avenue, okay? And there's Wilbur. He's 90 and appears to be dead. What do you do? Call 911. Now, what do you do? Very good. You're a smart doctor. Don't run around and scream and shout. Make the profession look bad, okay? Show them you know what you do. So you start CPR on Wilbur, and paramedics show up. They tube him. They put an AED on him. We have a big chest compression device called Lucas. You guys got that down here? Smashes the sternum against the spine. Very powerful. Drill a IO in his humerus, proximal humerus. Start giving him epi. Shock him. So I'm down here moonlighting. Someone let me in, and here comes Wilbur in the ER. and he's in asystole, 20 minutes. I bring the family in. I pronounce the time of death, 10:20. Now, very appropriately, everyone begins to cry. But you know what? Wilbur was just as dead at 10:19 as he was in 10:20, but in our culture, nobody's dead until we say they're dead, okay? Death is entirely a medicalized event. People cannot even recognize death and dying coming till they've heard it from the physician. So we got to be talking all along the way. Now, alternatively, Wilbur rolls in, and he's a big dude, so I do double biphasic defibrillation, and boom, return to spontaneous circulation. Is Wilbur going to live? You bunch of pessimists. You're right, okay? You're right. So that's not what the general public knows, because where does the general public get their information? Hollywood. That's exactly right. So what happens when you fall over dead on TV? We save you. And at the end of the TV show, you're at a cocktail party talking about how cute your doctor was, right? And this is CPR on TV. The patient's got nasal cannula on, right? Yeah. And then you shock them. Dink. And then the patient sits up and asks for a Coke and a smoke, right? Wow. No wonder people think that we're working miracles. They are on TV. Now, this is a true statistic. An ER doc in the late 1990s said, why does everybody think that we can do miracles? So he analyzed primetime TV dramas, ER, and the like. And it showed that 75% of the time on TV, it's portrayed that CPR is effective. And that 67% of the people who are coded wake up and are their normal selves. There you go. So what are the real stats? All comers, do you know? Pre-hospital and in hospital. 90% of people who are found dead stay dead, okay? And of those who are resuscitated, almost 50% have some new disability or brain damage. They're not, Wilbur, should he have survived, was not going to be who he used to be. This is what the general public does not know. And this is the truth that has got to come from us. We've got to be the ones to tell them. All right, so that's the 90-70 dilemma, and this is the product of that. And I want to tell you that you guys are doing something right down here. So this is data from the Dartmouth Atlas project. It's the largest end-of-life Medicare analysis to date. The data was collected in 2007. This was all reported in 2011, and it's too small for you to read, but I'm going to point out that these are percentages of chronically ill Medicare patients dying in the hospital. And I'm just going to show you that I live here in the highest, and you guys are doing very good. You're in some of the lower middle percentiles for chronically ill Medicare patients dying in the hospital. This is people who are clearly on the end-of-life trajectory. This is the number of ICU deaths among the same population. So you guys are doing better. I'm still in the bright red. Actually, I need to sit down and you need to be giving this talk, right? You guys are doing something right down here. And then the last one is average number of hospital days per chronically ill patient in the last 6 months of life. You guys are winning in the whole state. I'm very impressed. And I'm still at the bottom of the totem pole, which is why I'm speaking about this, because I live and work and have my being in a place where I think we got it all backwards. So that's the 90-70 dilemma. I don't know how we got there, but I do know that if we're going to change what we do and give patients what they want, what they say they want on the front end, that we've got to do something differently. So, do you remember when you first learned to drive? You remember that? I was sweating and had sweat dripping from my elbows. I was doing something new. And I got a 15-year-old who's learning to drive now, so I still got sweat dripping from my elbows watching her. So when you start something new, you're a little freaked out about it. So if you're not already having end-of-life conversations, you're going to start having them, you're going to be a little freaked out. That's fine. You'll get over it. You'll get over it. It'll roll off your tongue like any of the other taboo conversations we already have. So here are my recommendations. What we just talked about is unconscious. To do something different, this is conscious choice to deliver different care. So I think it's as simple as flipping the equation. We have to consciously find ways to help our populations decrease their dependence on the high-tech pathway at the end of life. We have to consciously find ways to help them increase the community's knowledge about death and dying. Like tomorrow here, they're going to be educating the population here about end-of-life issues. I'm very impressed. That's why you guys are doing so great. We've got to find ways in healthcare, believe it or not, to help families and patients regain intimacy so they can let go. Didn't think that was your job. It is a job, apparently. So let's talk about these in detail. How do we have average Jane and Joe on the street know more about death and dying? We have to educate them because it's no longer embedded into our daily lives. So such as the educational program here tomorrow. Each one of you is a member, probably, of a church, mosque, temple, synagogue, or some civic organization. You already have everyone's medical ear. You have their attention. People call you already and ask you about their hemorrhoids. By golly, you can bring up end-of-life issues. You carry some power with these people. You need to be the ones to teach them the truth. Secondly, we need better healthcare education. We need better medical school education. This needs to be part of residency. It really should be part of our CME requirements to maintain our licenses to practice. I mean, I love hospice and palliative care folks, but by golly, do we need a specialty to tell people that they're human? Their job is to help us manage complicated symptoms, not to go in and tell someone they're dying. That's our job, right? How do we help patients and families regain this emotional intimacy and closure at LifeSim? This is multidisciplinary. It does require hospice and palliative care and social work and chaplains. However, I don't know their job, but I do know that I must be the one to create space for the following to occur. The healthcare system needs to lead people to the honest truth. We need to move people past denial so that this amazing thing I'm about to tell you can happen. In the sure face of coming death, when a doctor says, Monica, you probably have 6 months to live. Those are hard words to say. They are harder words to hear. But if this person who's just received this news can move beyond denial into the first stages of working through this and acceptance, something amazing happens. An emotional window of opportunity opens for this person. Unlike any other time of living, there is an opportunity. In this emotional and spiritual window of opportunity, there's certain work that must be performed to allow all of the baggage of life to be worked out. I think there are 6 things that should be said to the dying or shared by the dying, regardless of anyone's ability to reciprocate. And we have to make space for this, okay? And that means telling the truth and getting into this bubble. So let's talk about the 6 things, because our day will come as well. Number 1 is words of forgiveness. Please forgive me. Forgive me for hitting you. Forgive me for leaving you. Forgive me for lying. Oof, that's rough stuff. Most of us live with this facade up. We allow people to see what we want, but the truth resides back here. When you know your time is limited, you need to work through this stuff. This is the only trip you'll ever go on where you unpack before you leave. We have to make space for people to unpack. The second thing that should be said is also words of forgiveness. I forgive you. I forgive you for lying and for leaving. I forgive you for hitting me. Number 3 is thank you. When my grandmother lay dying that night, I held her hand and said, Granny, thank you for feeding me. When I was 9, we became pretty poor, and I thought we were starving. There was some food. It just wasn't much. And Granny walked into my yard with a brown bag of groceries, and I felt like she saved my life. And that night on her deathbed, I got to thank her for that. It was a precious moment that would have never happened with the tube sticking out of her throat. Number 4 is, I love you. I'll love you forever. You have no idea how many people go their entire lives and never utter those words until someone lays dying. Number 5 is, it's okay to die. We must give our dying people permission to go. You remember Nelson Mandela lay over there for months and months in South Africa on life support. He was waiting to hear the words, "Father, we release you." I love that. That's South African cultural terminology for releasing a dying elder to the spirit world. I think here in Tallahassee, we should be able to say, "Mother, father, spouse, child, I release you." Number 6 is goodbye. Depending on your beliefs, I'll see you on the other side. I think these 6 things give the most release to that very precious time at the end of life. But here's my real question for you. Probably shouldn't we be talking like this every day? You see, 10% of us will die unexpectedly. I may not be here next week, but I have said the things that need to be said. Only 90% of us have a long, slow course to the end of life. We can sign up for hospice and they'll remind us what to say. Thank goodness. But what if you're the 10%? I'm an ER doc. People show up of all ages and die right in front of me. So I got it. I got this. Before I leave to go on trips, I gather my 3 girls together and I say, "I love you forever." And my middle child goes, "Oh, Mom, are you on your period again? Do you have to say that all the time?" Yeah, perimenopause will kill you, let me tell you. But the point is, if I died on the way to Tallahassee, Florida, and that's the last thing my kids heard me say, how powerful is that? So if we're going to counsel our patients, we should be living what we say. We should be able to walk our talk. So people deserve that. We got to make space for that in healthcare. The other thing that we need to be doing in this precious crucible of time is leaving a legacy. The definition of a legacy is a gift which transforms the receiver. And the story of your life, where you have done stupid things and heroic things, these are legacies for your unborn great-great-grandchildren who will never know you. Your patients need the time and space to make this, to transform the lives of their family. We need to give them that. We owe it to them. The real way to solve the 90-70 dilemma is to get people out of the hospital, onto hospice care, and home when it is appropriate. So what we know from recent studies is that it is in the ideal care at the end of life. As we move along the course of time, we slowly lose the ability to cure you, and we should be increasing our focus on palliative or comfort measures. There's a time in the best care possible where cure-focused care ends. Cure-focused measures end, and hospice care begins. In our present medical setup, this is the last 6 months of life. And here's what I want you to hear very clearly from me. Hospice care is not the kiss of death. It is the gift of life. And most of the people in the community think it's the kiss of death because we discharge the patient home onto hospice 2 days before they take their last breath. So by association, they have connected hospice with death. My dad, isn't he cute? That's my dad. My dad's been on hospice for a year. The photo on your left was 2.5 years ago. My dad has end-stage COPD. It was Thanksgiving. And I noticed that on his 2 liters of oxygen, he was having trouble walking up my stairs. And that day, it struck me that I couldn't believe I had not already started advanced care planning conversations with him. I mean, like, if he's already oxygen dependent and I hadn't even talked about it, I'm late in the ball game. So I'm from a family where we don't talk about this stuff, okay? It was so hard to talk to my granny that day. It was much harder to talk to my dad. He wasn't interested. But this is my dad 6 months ago, the right bottom picture. He's been on hospice for a year. He takes 120 of long-acting extended release morphine a day with morphine liquid for breakthrough to walk around. He wears 5 liters of oxygen. This day, he said, "Monica, do you think we could go to the casino one last time?" And I said, "Sure, Dad." I gave him some morphine drops and put him in the back of the car. He won $200 at blackjack. At the end of the day, right before I took this photo, this is our family selfie, he said, "Monica, thank you for bringing me. This has been perhaps one of the best days of my life." And I said, "Dad, I can assure you it's been one of mine." We're in this sacred space I didn't really know existed. One day a week, I go and take care of my dad. I shave him and give him a bath and trim his toenails and tell him that I love him. We never had this kind of relationship before. And this space is possible because of hospice care. His quality of life is far beyond anything that I had imagined for him at this point. And our emotional and social and spiritual life is way beyond anything I thought was ever even possible. This is a sacred time. And it was hard to start this conversation, but by golly, I'm glad we did, because this is what we got. I wouldn't trade anything for it. 90% of people want to talk to their doctor about end-of-life issues. Only 17% have done so as of last year, but the barrier to that is now gone. CMS, as of January 2016, has funded us to talk to patients to do the right thing. So here are the codes. Here's how you do it. CPT code 99497 pays you, and this is regional variation. I think you guys are a little higher than me, but on average, $75 to $85 for having a conversation with a patient or a family or surrogate or guardian about anything dealing with advanced care planning, end-of-life issues, making choices, code status, living wills, 5 wishes, blah, blah, blah. So this is the first 30 minutes. CPT code time rules apply, which means you have to pass the halfway mark to get the code. So really, you have to document at least 16 minutes on your charting to get the bill, to get it paid. The second code is 99498. This documents or pays you for an additional 30 minutes on that same day. So passing the halfway mark means you need to talk for a total of 46 minutes for that day. Now here are sort of some of the nuances of it. These are not one-time codes. They can happen on consecutive days. This is a conversation that must occur over time. Goals of care change. Healthcare status changes. Transition in care occurs. So it's not once and you're done. This is multiple times. It will be paid out on days, different days. It can't be billed on the same days that you bill critical care codes. You can do the documentation, but you won't get the bill for it. Any physician or advanced practice provider with their own Medicare number can do this work, okay? So this is, I told you earlier, you should have your nurse practitioner own this. They're uniquely skilled. If you're uncomfortable with the conversation, they're the right people for the job. In your handout is a group of facts. There's a fact sheet for more information on advanced care planning codes. So what do you talk about? Anything. How to choose a surrogate decision maker. What a good surrogate decision maker looks like. I do this code when I'm doing admissions. So this very week, I had a 92-year-old male, and this is what I wrote. 92-year-old male, end-stage dementia, here with UTI, is unable to make his own decisions, spoke with his daughter who's power of attorney. She wants to have a DNR order in place, which is consistent with previous known health care wishes and last admission, and she will accept IV antibiotics, but no ICU level care. 16 minutes, boom. Any of these things, there are no rules yet for what will be documented. Rules will probably come later. CMS is most interested in you just talking, starting the conversation. There are different conversations that should take place at different points in time for the patient. In the physician office, we should be doing long-range advanced care planning conversations. That's living will or 5 wishes. You can do it with the 19-year-old, you can do it with the 40-year-old, the 60-year-old. This is where you're really educating people about what they need to know to make decisions and to choose surrogates. Then there's the middle range. So this is for people who are actively navigating the course of age or chronic or terminal illness. You really need your palliative care folks involved. They have a way of sitting down and saying, who's your favorite football team? Tell me about your life. So they're the ones that should accompany you with concurrent care, palliative care along the course of illness. So I'm an ER doctor. I have to make what I call stat proximate decisions. I have 3 minutes to decide what to do next, so the favorite football team doesn't have any relevance to what I need to do. I need either tube you or not. So there's a different set of conversations that I need to have. These are some of the basic questions and answers that you can document and get paid for in a clinic or office setting. Talking to patients about where they are on the map of life. Does the patient understand where they are on the map of the life or the prognosis or course of their illness? What happens if you don't plan? Hell hath no fury like a family fighting over your fate. Y'all have seen that. Okay? Warn people. It can be very bad. Advise how to talk to loved ones. Teach your patients how to bring this up. Do it over a turkey dinner, do it over a letter, whatever you need. Why should you choose a healthcare agent, and what kind of person should you choose, Because by default, if you don't choose, the loud person from the family shows up to run the show, and we see that all the time. Have the patient explain the range of powers they're going to give their proxy. Have them write their detailed healthcare instructions. Who should have a copy of an advance directive? How often should it be updated or reviewed, and where should it be stored? Any of these conversations you can document and bill for, and it's the right thing to do. So this is a little mnemonic for the stat conversations that need to occur in the ER or hospital admission or at the time of an ICU admission. So I think this brings it down. So L, it's called lead. L stands for lead with an emotional connection. And this is what I say. Remember, we cannot divorce emotions from end-of-life decision-making, so we need to engage people's emotions. I say, listen, I want to talk to you like you're my sister or my mother or my family member. You can see the block immediately drop away. Or if it's the patient, I'll say something like that. I want to talk to you like you're my mother, and I'd talk to my mother the same way. Or I care about you, and I want to make sure that what I'm about to do fits your idea of what you want done. So speak of emotions and connections to start. E is explain the risks, benefits, and alternatives to whatever's being offered. Risks, benefits, and alternatives to CPR. Risks, benefits, and alternatives to feeding tubes. What are you about to do? Risks, benefits, and alternatives. And make a recommendation. We know the bottom line. Remember, the average American doesn't. And so do make a recommendation. We try too hard to be objective in medicine, but we really know. For the rest of the course of care, we make recommendations. We say, we think you ought to do this. This is what I want to do. And the patient invariably goes, okay. But suddenly at the end of life, we normally say, well, here are your options. Now you decide. What do you want to do? It's the first time they've made an independent decision in healthcare. It should be shared decision-making even to the very end. Ask and answer questions. What are you afraid of? What really worries you about this? And D, document your conversation and time spent. So quick mnemonic. Here's a quick toolbox for decision-making. This should be a normalized conversation. Tell your patients, I'm not picking on you. I talk to all my patients about this. Every patient who is admitted to our hospital through the hospitalist service has a code status documented. We talk to everybody, whether you're 19 or 55 or 105. We have that conversation. That's documented. The conversation starter kit, which you'll have available, is a very gentle way to introduce your patients into this discussion. 5 wishes, legal in the state, very holistic advanced directive document. There's a copy for those of you who don't have an advanced directive in your folder. And then for patients who already are at the phase where ICU aggressive care is not desirable, a do not resuscitate order should be agreed upon and signed by you. In closing, I'd like to tell you that good advanced care planning leads patients and families to a good death. And I'll tell you what, I didn't know that death could be good until my grandmother showed me firsthand. And so, of course, I had to study hospice and palliative care literature to understand what a good death was. That didn't make any sense to me. But out of hospice and palliative care, there are criteria that apparently, if the patient and family experience these, there is a perception that the death was as good as it could be. And so here's some of the criteria, and these are reproducible, okay? Reproducible. Number 1 is a sense of control, including knowing and honoring the wishes of the one who's dying. We need to know the wishes to honor them here, okay? Here I am in the ER. Don't try to know the wishes here to honor them here. This is a time of chaos, okay? But if we can know them upstream, we can navigate it and have a soft landing. Number 2 is assuring comfort and dignity. That's all of our job. Number 3 is trust in the healthcare providers. I tell my patients, you can trust me. I also tell my lay populations, if you do not trust your doctor to talk to you about end-of-life issues, or you do not believe your doctor will appropriately refer you to hospice, fire them and find another doctor who will. The whole quality of your end-of-life experience depends on being supported by your physician. Next is recognizing and accepting coming death. Okay, so think about this. A good death is one you can see coming, right? So in contrast, a 20-year-old who's hit by a car, that's never going to be good. That's not, it's devastating. There's nothing good about it. I can't redeem it. But no 89-year-old with end-stage anything disease should ever have an unexpected dying. We should see that coming. That's an opportunity for a good death for the patient and the family. Honoring the patient's beliefs and values, a sense of closure, including words of goodbye, that's our 6 things, and then physical contact. They say that hearing and touch are the last senses to go. The VA, for as much of a bad rap as it is getting, is doing something right. They have a group called NODA, No One Dies Alone. And volunteers come and sit with dying vets and hold their hands, many of whom are alone or estranged from their family. What a priceless gift. So I'd like to end with a story, because I'm a different doctor than the one I told you about in 2010. I try to give my patients a good death. I try to talk to people about advanced care planning. I try to prepare people. And it's now easy for me. It's not scary, but it took a while to get there. And so about 2 years ago, I had paramedics call ahead. 60-year-old man, respiratory distress. I thought, oh, here we go again, right? So he rolled around the corner, and the gentleman had JVD to the roof. He had a BiPAP on. His pressure was 250 over 150. He had bubbles coming from his airway. He was in florid pulmonary edema. Too short of breath to tell me his wishes. He also looked chronically ill outside of this event. AICD-in, had an EF of 10%. So his wife was standing outside of the door, and I started a nitro drip on him and blah, 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 Lasix, this, that, morphine. And I opened the curtain to go find out his healthcare wishes. And there she stood shaking, holding his living will. I was like, oh, my people, somebody who's talked. And so I say very quickly, ma'am, please tell me your husband's healthcare status, what's going on with him. He's dynamically ill. I need to know what to do or not do next. And she said, well, Dr. Murphy, he's got leukemia and bad congestive heart failure, and he's been on a breathing tube before. And just this last week, we sat down and did this thing with our doctor. And my husband said, under no circumstances did he ever want to be on a breathing tube again. And I said, I can honor that. She said, he doesn't even want any CPR. And I said, I can honor that. She said, and we're Jehovah's Witnesses, we don't want blood. I said, I can honor that. Looking at him, that's part of the problem. His mucous membranes were the color of the sheet. So I said, let me go back in and stabilize him, and I'll bring you in. But I went back in the room, and the man was no longer tripoding in respiratory distress. He had gotten relaxed, and he was looking up toward the corner of the room, and his respirations were dropping. He's in respiratory failure. So knowing that I had reached maximum therapy this man would allow, I went and got his family, and I began this process. His 6 adult children had shown up. And I said, I'm so sorry to come and tell you this, but if we're going to honor your dad's wishes, and I think we should, you need to know that he's showing dying signs. I've got him on the maximum support that he wants. But you can trust in me. I'm going to assure his comfort and dignity. And let me tell you what we're about to see in this room. I prepared them for the pattern of dying that would occur, what he would look like, what his skin would do. And I said, I'm going to make sure that he's comfortable with medications. Do we need to call in a chaplain? I need someone to support you in your beliefs. Then I told the family, please come in and hold his hand. What needs to be said? Thank you, I love you, goodbye, forgive me, whatever comes to your heart. And so all 6 children came in the room, and the wife, and they formed a circle around this man. And I gave him little pushes of morphine. And the eldest daughter held one hand, and his wife held the other hand. And this is what the eldest daughter said. She said, Daddy, I want to thank you for taking care of Mama all these years. And I hope my boys grow up to be like you, because you've been an honorable man. And I want to thank you for working 3 jobs to feed us and put us through school. But today's your day, Daddy. Dr. Murphy said it's your time to go. And we love you. We will love you forever. And I'll see you in paradise. And she kissed him on the cheek. And 5 minutes later, he died. And it was good. It was holy. It was sacred. And it was just as it should be for our patients. I hugged this woman and I said, I want to thank you so much. You've given your daddy a good death. And in the end, it's the most any of us can hope for. I said, I'd be so honored if one day my daughters can hold my hand and say the same words. What a blessing. And I looked at my staff and I said, they just showed us how to do it. All of our patients deserve this. So here's the bottom line. It's up to you. Now, if you're lucky, you'll never see me again. And after all this, I'm sure you're happy about that. But here's the deal. It's up to us. It's our jobs. What we do and do not do matters. Our thoughts and beliefs create the system in which we live and work, in which we will ultimately die. You and I and our children will die in the hands of the medical system that we've created together, my friends. And I hope that it will be a good death. And I thank you for your time. Thank you. I accept questions, comments, and Rotten Tomatoes, and there's some other resources I passed out too. Yes, sir. Are you just stretching?
No.
Yeah.
I really appreciated that talk. And one thing I wonder, in the case of somebody that's hospitalized in the ICU, as you described, even though possibly it would have been better in a room on the floor, some hospitals have bioethics on
Yes.
staff.
Mm-hmm.
I just wondered if you wanted to say something about the role that they can play.
Yeah, sure. So I'm on the ethics committee at our hospital. I wrote an ethics chapter for emergency medicine on the end of life. And I'm not trained in ethics. I fell into ethics because end of life issues is very much an ethics topic. So if a patient or family member is in crisis about the decisions being made, an ethics consultation may be paged. If the physician is having an issue, like they don't want to continue life supportive measures, but the family wants it, an ethics consultation may be called. And nurses who are in moral crisis about the care they're providing, who feel that it's wrong, anybody along this entire spectrum may call an ethics consultation. Most ethics consultations work the same way. A nurse, social worker, or physician comes in and assesses the situation and tries to get everybody's perspective and to come to some consensus, right? Everybody's trying to avoid medical legal issues. And so sometimes in our ethics committees, we are able to come up with an answer or solve a problem, and sometimes we are not. So we can't solve all problems with it, but it is certainly available.
How do you handle responding to the patient who begin to speak? I don't want to know.
Yes. Okay. Right. Okay, so certainly many ethicists will say that you should ask the patient what they want to know about their healthcare issues. And most palliative care doctors are trained to say that. And I have a slightly different stance. I tell people you can't make a decision for yourself without knowing the bottom line truth. And I say, I'm so sorry, I'm going to tell you what I know. So I kind of override that because I really feel like that they can't be a shared partner in their care unless they know the honest truth. Now, some cultures want a certain family member to be the decision maker that receives all the information and let that family member be the decision maker for that patient. And I actually generally try to respect that. So that's kind of an exception to the rule. Is some indigenous third world countries, that's the norm for them. But I do try to make a point to getting the truth to the patient as well. Many ethicists would disagree with me. Thank you, guys.